objectives for this presentation include, by the end of this presentation, we will be able to discuss the following about AML: the definition, the pathophysiology, the signs and symptoms, the disease process, treatment plans, and also care plans that go along with this disorder. Outline for our presentation, we will discuss the definition, description, incidences, risk factors, the pathophysiology, common signs and symptoms, diagnosis and prognosis. We also will discuss ethical issues pertinent to the injury and disease process, impact of the injury disease process on the individual, family, and society, and a plan of care appropriate for the patient with this disorder. What exactly is AML? Acute myeloid leukemia is a type of cancer of the blood and bone marrow in which the bone marrow makes abnormal myeloblasts, red blood cells, and platelets. Some history about this disorder include it was discovered in 1827 by a French physician. The first known patient to have this disorder was a 63-year-old lady. In 1845, a series of patients died from the same disorder, but at that time it wasn't named. After the deaths occurred, disease was named leukocythemia, and the term leukemia was coined by Rudolph Virchow in 1856. In 1889, it was introduced, the term acute leukemia was first introduced, and the rates of death with this disorder helped further categorize this disease. In 1879, leukemia was then categorized into either myeloid or lymphocytic, and in 2008, AML became the first cancer genome to be fully sequenced, which means you can see it on the DNA. They actually know how the DNA strand looks. Incidence report, the lifetime risk of developing cancer. Approximately 1.5% of men and women will be diagnosed with leukemia at some point during their lifetime, and that's based on the data from 2010 to 2012. In 2012, there was an estimated 318,389 people living with leukemia in the United States. And then the following about the next data is per 100,000 deaths, and this is the number of new cases of leukemia was 13.3 persons per 100,000 deaths in men and women per year, and the number of deaths were 7.0 persons per 100,000 in men and women per year, and these rates are age adjusted and based on 2008 to 2012 cases and deaths. And as you can see with the incidence bar graph, AML, which is in the orange, is the second most prevalent cancer, and CLL, which is chronic lymphatic leukemia, is the first most prevalent cancer. As far as risk factors, being male, they said more males have it than females. Smoking, which we all know as nurses that smoking causes a lot of disorders. Chemotherapy and radiation treatment. A history of ALL, because acute blastic leukemia at some point can turn to AML, and then that's when the treatment changes. Radiation exposure and blood disorders such as myelodysplastic syndrome can also predispose you to AML. More risk factors, 54,270 new cases of leukemia are reported every 5 years. 20,830 of the new cases are AML, and all those cases of AML, almost half of them would die. 10,460 deaths reported from AML. And the average age of this disorder is 67, but they see it in kids, but age greater than 45 is what you see the most in.
So let's talk about the pathophysiology of AML. The underlying pathophysiology in acute myeloid leukemia consists of a maturational arrest of bone marrow cells in the earliest stage of development. It involves the activation of abnormal genes through chromosomal translocation and other genetic abnormalities. The development arrest results in two disease processes. First, there's a marked decrease in normal blood cells, resulting in anemia, which is a decrease in red blood cells, thrombocytopenia, which is a decrease in the platelet factor, and neutropenia, which there's an increase in white blood cells. Second, the rapid proliferation of these cells results in their accumulation in the bone marrow, the blood, and frequently in the spleen and liver. The malignant cells in AML are the myeloblasts. The myeloblast is an immature precursor of myeloid white blood cells. This myeloblast matures into a mature white blood cell. And in AML, a single myeloblast may undergo the genetic change that fixes the cell in its immature state and prevents maturation and differentiation. In the majority of cases, this mutation alone is incapable of causing leukemia. When this mutation and arrest in the immature stage is combined with other mutations, however, which disrupts gene control and proliferation, the condition may arise to AML. Leukemic transformation can occur at a number of different steps along the differentiation path of the myeloblast. The classification of AML follows the stage at which the maturation of the myeloblast is arrested. Here's two pictures of that cell cycle that I just explained, and you can see the stem cell and the progression and expansion of those cells, whether they're tumorous or not. So common signs and symptoms. The signs and symptoms will kind of mimic the white blood cells, the red blood cells, and the platelet factors. With fatigue, anemia, you would see a decrease in red blood cells. Infection and fever, you will see a decrease in the white blood cells. You also see a decrease in appetite, low platelet counts, which may cause bleeding. You may see red spots under the skin, petechial rash. You also may have weight loss and weakness.
Okay, some diagnostic testing. You can make it a physical exam and history. During the physical exam, like was said earlier, the patient may come in complaining of fatigue and weakness, and explain weight loss, petechial extremities. They'll be pale and decrease in appetite. And their history is higher in males if they're a smoker and if they have a history of ALL or MDS. For the complete blood count, you're going to test their white blood count, platelets, red blood cells, and H&H, with the focus mostly being on the white blood cells. With peripheral blood smear, what that is, it looks for abnormalities within the blood cells and are examined under a microscope for unusual shapes and sizes. And then you also have bone marrow aspiration and biopsy. And what that looks for is the leukemic cells, which are your myeloblasts, in addition to the red blood cells, white blood cells, and platelets. With your cytogenetic testing, this is the type of genetics that's concerned with the study and structure and function of the cells. The blood testing part of it, it does an analysis of the blood or the bone marrow, and it looks for specific gene mutations in certain leukemias. And then with your immunophenotyping, that's the process used to identify cells based on the types of antigens or markers in the surface of the cell. And with your reverse transcription, this is the synthesis of a single-stranded DNA using single-stranded RNA as a template. And this usually is associated with your retroviruses. And this is a picture of a peripheral blood smear, and it's showing the abnormal myeloblast here. Your treatments will include chemotherapy, radiation therapy, stem cell transplant, and drug therapy. With your chemotherapy, you're going to use to stop the drugs. Use drugs to stop the growth of the cancer cells. It works by either killing the cells or stopping further growth. And it can be taken by mouth, injected into a vein, or injected into a muscle. And they usually use a combination of chemotherapies. With your radiation, you're going to use high levels of radiation to kill the cancer cells. And it's going to either be external or internal. It depends on the type and the stage of the cancer. With your stem cell transplant, that involves giving the chemotherapy first, and then you're going to replace the blood-forming cells. The stem cells are removed from the blood or bone marrow, and they're frozen. They usually want to give the patient back their stem cells, but they can't get it from a donor. And after treatment, the stem cells are thawed and given back to the patient. New stem cells restore the body blood cells.
prognosis. Overall, of all those with AML, around 20 out of 100 people will survive for 5 years or more after they are diagnosed. People less than 21 years of age often recover better than older individuals. And those aged 14 or younger, around 66 out of 100 people will survive for 5 years or more after they are diagnosed. And those aged between 15 and 24, around 60 out of 100 people will survive for 5 years or more after diagnosis. And those aged between 25 and 64, almost 40 out of 100 people will survive for 5 or more years after they are diagnosed. And those aged 65 or older, around 5 out of 100 people will survive for 5 years or more after diagnosis. Ethical issues. There may be ethical issues related to the patient's personality, religion, culture, socioeconomic status, personal and family life. End-of-life care must be discussed. Treatment may involve blood products which are against certain religions. Resolving ethical issues. Most of the ethical issues need to be resolved using high degree of sensitivity and very good communication. At any time, the laws of non-maleficence should be applied. Cultural purposes must be addressed before treatment. End-of-life advance directives should be discussed. Some of the impacts of AML, patients and family may experience sadness, depression, anger, and or fear. It can turn their worlds upside down financially, emotionally, and physically. When caring for someone who is sick, it is natural to feel burdened by all the new roles that have been entrusted upon them. It is important to remember that your role is not to be everything to everybody, but rather to be the best you can be. Treatment is available to each individual who seeks treatment. There are programs available to assist people who don't have health care. There are programs available to help with the cost of treatment to individuals without insurance. Will the insurance cover the treatment? If your plan has too many out-of-pocket costs, or if its prescription plan is not very generous, you may consider switching plans during the next enrollment period if that's an option. Unfortunately, the cost of leukemia can add up considerably, even when you do not have insurance. Someone who has leukemia may have a doctor's visit 3 times a week. So a $10 to $30 copay can be quite a burden. And some people who have bone marrow or stem cell transplant need as many as 50 medications afterwards, and each drug can carry a copay of $100. How expensive is the treatment? Some transplants can run up to $500,000. Leukemia is a financial burden for people who don't have insurance and for the people who have insurance. How AML affect normal life events? Cancer has the greatest effect on marriage and long-term partnership. After a diagnosis of cancer, both individuals may experience sadness, anxiety, anger, or even hopelessness. For some couples facing the challenges of cancer together, strengthens their relationship and commitment. For others, especially those who struggled in their relationship before the diagnosis, the stress of cancer may create new problems or worsen existing problems. Although you may want to protect your children from fear or other difficult feelings, it is important to talk openly with them about your diagnosis and treatment. Are there support groups for individuals and families with AML? Yes. There are several support groups that are available for families and individuals. You can find additional resources by contacting the American Cancer Society or going to www.lls.org.
Okay, we're gonna talk about some nursing diagnoses with patients with AML. They may have imbalanced nutrition, risk for infection, risk for bleeding, risk for falls, impaired mucous membrane, fatigue, risk for caregiver strain, disturbed body image, fear and anxiety, and knowledge deficit. We'll discuss the top 5 diagnoses. First one, imbalanced nutrition. With that, your physician may order a patient with a diet high in protein and calories. He will order a switch and swallow solution for the patient to help alleviate oral discomfort. Some nursing implications: the nurse will administer nausea and vomiting medicine to prevent the patient from getting nauseated. They'll encourage diet high in protein and fiber. They'll monitor the intake and the output. And the nurse and the clinical dietitian will provide dietary counseling and teaching to include avoidance of raw fruits, vegetables, or uncooked meats. With risk for infection, your physician will order daily labs. They will closely monitor the CDC, noting whether the WBC count falls or sudden changes occur in the neutrophils. The physician may also order and review serial chest x-rays to make sure the patient is not getting a secondary infection like pneumonia that'll complicate their course. Some nursing implications: you're going to monitor their temperature. You're going to put them in contact with cautions because you want to protect them. You want to observe the signs of infection, including with that, besides having an elevated temp, they may have some tachycardia, some tachypnea, some optimum status, something else going on with them besides just the temperature. You're going to encourage frequent coughing and deep breathing to prevent atelectasis and pneumonia. And then you want to avoid unnecessary introduction of infections like catheters and anal injections. For your risk for bleeding, your physician will order replacement of your RBCs, platelets, and clotting factors. He will also order labs that monitor the H&H, the platelets, the PT, PTT, and INR. Some nursing implications will include inspect the skin and mucous membranes for petechiae and ecchymosis areas. You're going to note the gums for bleeding, occult blood in the stool and urine, and also note oozing from around invasive line sites. You're going to prevent tissue injury, and you're going to avoid iron injections and needle sticks when possible. Okay, for risk for falls, the physician may order group and home-based exercise programs. And they usually contain some type of balance and strength training exercises which will effectively reduce their risk for falls. The nurse will come out and they'll utilize the fall assessment tools to screen an individual risk for falling, and then carry out treatment or arrange referrals to reduce the identified risk. Like here at the hospital, we put them on high risk for falls and do fall assessments every 2 hours. And the nurse will assess for home environmental hazards, like when they go home, to make sure they don't have a cluttered environment, make sure the lights are appropriate, make sure they don't have loose carpet in the house, slick floors, etc. The nurse and physical therapy will provide training to the patient and caregivers in skills needed for daily living, such as transferring from the chair to bed, or either chair to the hot chair, or getting up, how to get up, holding, the proper way of getting up from a sitting position to a standing position. And physical therapy will provide training in the use of assistive devices, example, the use of the walker and cane. For impaired mucous membranes, the nurse will report signs of infection. The nurse will encourage good oral hygiene by using a soft, bristle toothbrush 2 or 3 times daily and rinse frequently and floss daily. The nurse will encourage the use of oral. The nurses will assess for antifungal, antibacterial, or antiviral therapy, but sometimes they're prone to get thrush and have sores and stuff in the mouth. And then the nurse will administer local oral therapy such as a combination of viscous lidocaine. Okay, discussion.
Have any one of you ever taken care of a patient with AML? Okay. What role did you play in providing care for the patient? Were you primary nurse?
Primary nurse.
Okay. And what was your plan of care?